Welcome everyone to today's Health IT Symposium. During the presentation, all participants will be in the listen-only mode. Should you wish to ask a question during the presentation, please use the Q&A feature. This symposium is a collaboration between the National Center for Primary Care's Faculty Development Program and Hybrid Solutions. I'm Shanae Lee, Associate Project Director of the NCPC Faculty Development Program at Morehouse School of Medicine. The mission of the Faculty Development Program is to provide resources and education to faculty, clinicians, researchers, leaders, and scholars that will improve knowledge and skills. I'm glad you all could join us today to talk about the growing healthcare industry. Your host today is Phoebe Nelms, Program Manager with the Health IT Division, Hybrid Solutions. Phoebe?
Thank you so much, Shanae. We're all very excited to partner with Faculty Development to bring this event to life. So get ready for a fast-paced information upload. We intend this to be an engaging discussion with industry experts who will share actionable insights on where we are on that journey to interoperability. We'll also talk about the requirements of the 21st Century Cures Act and how it will impact the delivery of care in your healthcare organization. We also have a segment on what's happening in Georgia, as well as an interactive panel discussion focused on using digital health technologies to improve the quality of care, care coordination, and enhance the communication between physicians and patients. Mahatma Gandhi said, "It is health that is real wealth, and not pieces of gold and silver." And so the mission of the National Center for Primary Care is to strengthen the primary care system and work that it does to keep us all healthy through educational events like this one. And now I have the pleasure of introducing Dr. Dominic Mack. Among his many titles, Dr. Mack is the director for the National Center for Primary Care here at Morehouse School of Medicine. The Faculty Development Program and the Health IT Division fall under his leadership. The Health IT Division's executive director is Carmen Hughes, and the Health IT Division includes Hybrid Solutions, Hybrid HIE, Health Information Exchange, and our new project, Aim Ahead. We are looking forward to hearing from today's diverse group of healthcare experts. And now, Dr. Mack, you have our attention.
Thank you, Phoebe. And I want to thanks Shanae. I want to thank all the panelists we have today, and we really thank our audience for chiming in. Just a few words I'd like to add today is about the Faculty Development Program. A little history. Faculty Development Program was started in 1992 within the Family Medicine Department of Morehouse School of Medicine. We were experiencing challenges retaining minority faculty at that time. And the Association of American Medical Colleges reported that there were only 52 African-American full-time academic physician faculty across the nation. And that started the development of this program. And studies since have identified, I know in 2013, there were only 7.5% of faculty members who identified themselves as underrepresented faculty across this nation. So the Faculty Development Program is so important to develop minority faculty who serve at minority institutions, but also majority institutions. So that's the purpose of the program. So Phoebe kind of gave you a little background about the National Center for Primary Care, but that Faculty Development Program followed Dr. Russ to the National Center, from the Family Medicine Department to the National Center for Primary Care. And of course, we have other programs. The HIT program, health policy is another one of our cores, along with our research core. So we do a lot of big data, health equity research here. We do a lot of implementation science, especially on the HIT division, where we implement, since Meaningful Use, we've been implementing programs around technology in the United States, and now we actually have some programs in Zambia. But anyway, just want to say hello to everyone and thank you and welcome you today. And I want to turn it back over to Phoebe.
Thank you so much, Dr. Mack, for highlighting the important work being done here in the National Center for Primary Care. We eagerly anticipate the information and the opportunities for collaboration that this symposium will produce. Next, we'll give our attention to Dr. Gary Ozanek, a senior consultant for Health Tech Solutions and director of the graduate program in Health Informatics at Northern Kentucky University. His extensive experience with the Office of the National Coordinator, ONC, and the Health Information Management Systems Society, HIMSS, also informs his topic today. And although interoperability seems to be an elusive goal, help is on the way through ONC leadership and direction. Dr. Ozanek, please tell us more.
Thank you so much, Phoebe, and it's a real honor to join you this afternoon. An agenda today, and as suggested, Phoebe suggested, it's going to be relatively a quick fire, and we're going to be going through a lot of information, and look forward to any questions that you have and would like to include into the chat, which we'll take in at the last part of this presentation. So what I want to talk about today is data integration and clinical practice, and some market-based and policy solutions, and then finally a future vision, and ideally engage some of the attendees in thinking about what that future should be. Next slide, please. So this is really about interoperability. This is about levels of data integration, right? I mean, interoperability is about getting ideally health data to the right place at the right time. But what we're really concerned about is being able to integrate data into, various use cases, whether it's the point of care or care coordination or quality reporting for MIPS or other value-based programs. Also, ultimately for population health, and data integration is more than just the sort of structured clinical data. We often think about, clinical measures that are actually much easier to deal with than the more important, health equity measures of social determinants and the like, which tend to be unstructured data or semi-structured data. So there's a lot of complexity in data integration, but just to sort of give you a map for looking at data integration and interoperability, the question is workflow. If it's not really being supportive of workflow in the specific use cases where it's important, clearly there's limited utility, and perhaps providers and others may not take full value of the data. So where we really started before the Meaningful Use program was a lot of siloed data within one health system, and ideally now we're moving toward higher levels of integration where there's much more integration into workflow. Then usability, and we're going to talk a lot about usability, because if you get data to the point of care where it's not useful, it's really not true interoperability or data integration. And then finally, the technology. And we start, focusing initially a lot on technology, but increasingly we're going to be technology agnostic, and we just want to have a semantic understanding of the data across all settings. That is, the ability to map data across a variety of settings. We're just finishing a study right now, and actually next week, Wednesday, we're doing a webinar for HIMSS on a project that ends on March 31st. That's funded by ONC and by ASPE. And we've been looking and talking to organizations and case studies about, what level of integration they're at, and how they use data. And the major takeaway that we came up with is that we automatically assume you want to be in the lower right. You want to be as far to the right as you can in terms of this map. But in reality, in some cases, you don't need the highest levels of data integration. Viewing data is sufficient, as opposed to, you know, the need for parsing data. And we'll touch upon that again as we go through. This just sort of gives you a roadmap on where we are in terms of interoperability. If you're able to send data, that is, send it through an HIE or Care Everywhere if you're an Epic customer, or Commonwealth or the eHealth Exchange, any one of the various exchanges. And you can see hospitals are way out in front of office-based physicians and you know, home health agencies and SNFs. You can see how we look across the spectrum here. And then if you're able to receive data, are you able to find data and look for data that you need? And then ultimately, can you integrate data into your workflow? Are you actually using the data from outside sources when you're seeing a patient? And as you see, there's, you know, a significant drop off. I mean, it's easy to send the data. It's easy to receive the standards-based data, but then can you really integrate it? And can you use it to basically find the data you need? And you can see various care settings, you know, not surprisingly, skilled nursing facilities and are lagging office-based providers or hospitals. So we still have a ways to go. And that's, you know, the baseline we're sort of looking at right now. And we want to talk about how we're going to make things better. Help is on the way. Next slide, please. So key uses of data interoperability and data integration are point of care, where you see a patient that is, you know, during the actual encounter. Example of this is looking at the health information exchange, such as GHIN, and seeing the patient record, or if you're an Epic customer, looking at Epic Care Everywhere and being able to see that a patient has been seen at another location, or has had recent labs or other tests. You can cut down on relative redundant tests and the like, save money, and also get the most recent information on the patient, particularly when medical histories may be complex to capture. Care coordination, obviously, between transitions in care, whether hospital release from hospitals, linked to, you know, 30-day readmission concerns and the like, or between post-acute care and hospitals. But also a key element of care coordination is referrals to specialists and getting information back when you're referring a patient for care coordination. So point of care and care coordination really do not require the level of interoperability or the level of data integration. You can basically view, you know, past data in the patient, and it's sort of good enough. And that's where we are. Even if you're looking at a single vendor system like Care Everywhere or Commonwealth, the providers are really looking at the data. It's not being integrated into a single patient record. Quality measurement and reporting is a third area that's obviously linked to MIPS. We've just been doing a lot of organizational interviews as part of the study I mentioned earlier. And we're hearing from providers that their quality scores actually go up when they're able to get data from other sources and integrate it into the into the record for the patient they're reporting on. You know, whether it's tests being done elsewhere or follow-ups or whatever the particular HEDIS measure might be. Population health is really the future. I know you're going to be talking about AI today and predictive analytics, tracking, public health linkage. Boy, we've learned a lot about COVID in the last 2 years and the gaps in terms of interoperability relative to public health and population health and the like. So that likewise requires, you know, very carefully mapped data, and it is quality measurement reporting and pop health really are use cases that really require a lot of data curation, a lot more expense than the first two use cases. So what are the challenges to data integration? we have technical interoperability. You have, if you look at non-certified EHRs, for example, if you look at long-term post-acute care, probably depending on what state you're in, 60 to 80% of the market is point-click care, and they don't really, they're not a certified EHR because they were not included under the original meaningful use requirements. You also have a lot of issues about the technologies being used and the standards being used. And I'm going to talk about this. The specificity of standards is really important. I mean, I think the big lesson we learned in the last, few years is really, even though we have good standards, you can exchange data and it may not be usable at the receiving location. The standards have to be very, very specific. And we're going to talk about solutions, particularly in the form of a standard called FHIR and Smart on FHIR. That's a solution for that. Semantic interoperability refers to data mapping. That means if you're mapping an A1C from one provider into another vendor system, that it's recognized and placed in a usable format so you can understand it. Semantic interoperability is different than technical interoperability, and in many ways much more expensive to achieve and much more difficult. Then also challenges is workflow integration. How easy is it to use and how complete is the data? And then the data characteristics themselves, structured, unstructured, and semi-structured data. As we're learning, so much of the important data is really unstructured. So much about healthcare and issues of really moving the needles in terms of care has to do, as you well know, with social determinants and with other data elements that are not very easy to map between systems. It's much easier to map a lab value between a system than it is to map text or even a checkbox survey. So the data characteristics are another challenge to data integration and interoperability. So what's enhancing data integration today? Next slide, please. So the marketplace really is at an inflection point. If you've been involved in healthcare during the stages of meaningful use and promoting interoperability as it was shifted to in 2016. It used to be the standing joke, and I served on various committees at HIMSS and in various capacities, but the standing joke always was that meaningful use was actually meaningful abuse for the providers. That so much of the initial introduction of the technologies required a burden on providers. And certainly what ONC is doing today, and I had the opportunity to work on the EHR reporting program, which is currently in a public comment phase, which is a identification of new standards for EHR developers to be certified under ONC. But one thing we've really come to understand and appreciate is relieving burden on providers. Technology should help providers. It should not be a burden on providers. And during our last few years, and particularly the initial years, a lot of the technological adoption was just not supported or justified given the utility of the products that were being used and adopted. And in some cases, you still have reports of providers being held captive to EHRs that they really can't get out from under on a relative to financial burden. So the idea is really to really look at the certification technology, and a key element of the certification technologies that continues to evolve is to reduce provider burden. So technology is shifting, but standards and policies are being refined. the current policies and current standards are somewhat cumbersome for interoperability, and that's been recognized by the ONC and certainly is recognized by the marketplace. There's a technology that we'll talk about called FHIR, Fast Healthcare Interoperability Resources, which is going to change the nature of exchange. ONC is certainly making a substantial focus on FHIR and its ability to solve some of the interoperability problems that we're facing. APIs stands for Application Programming Interfaces, and that's really the backbone of the internet. So, for example, if you go to an Amazon site to look at a product, it's my understanding, the quote I've always heard is that on average it'll connect to 54 different information sources through application programming interfaces. So as you'll see, we're going to be moving away from so-called document exchange of large portions, large documents in the form of continuity of care templates, and moving to what is now the USCDI data elements, and we'll talk about that in just a bit. So we're going to move more to point-to-point transactions and away from these bulk standards. Also, you have national networks. You have the eHealth Exchange and you have TEFCA, which are certainly designed to provide fewer hops in terms of exchanging data and potentially allow for providers to, connect through an HIE-like organization in regions where there's no HIE. You have vendor networks, and I often joke that I suffer from Stockholm syndrome, and that I'm actually a really big fan of Epic's Care Everywhere network. I think it does a really good job for its customers. But you have Commonwealth also, which is sort of the Cerner and the other vendors, and they've certainly become affiliated with the national networks. So ultimately, we're going to have a variety of competing and complementary ways to exchange information, and I want to talk about some specific ones that are going to make your life easier. So the drivers for interoperability is the movement to value-based reimbursement and risk-sharing models. I mentioned that, in some of the recent interviews we've been doing with providers, and the providers were specifically identified based upon their involvement in value-based accountable care organizations. They've identified that getting a full picture of the patient from every place possible really has improved their reimbursement and the upside in their risk-sharing models. Population health and analytics, you'll talk about this later this afternoon, but clearly predictive analytics, big data, data warehouses, data lakes, and the like. Payer engagement, increasingly the payers and providers are exchanging some data within a health information exchange. There is still a significant trust component that needs to be encouraged between providers and payer organizations. In the research work, the survey work we've done, we still hear that providers are worried about sharing all their clinical data with payers because the payers may use it to complicate pre-cert and stuff like that. But that's another area where there is movement, simply because if you're in a risk-sharing model, you're going to have to share data. And then open standard application programming interfaces like FHIR and consumer-directed exchange. One element of the Cures Act really is to require the ability for third parties to use APIs, to basically use FHIR or proprietary APIs to aggregate consumer data and allow the consumer to direct exchange between various providers. So, theoretically, you could have a large company like well, I doubt Google would want to be in return to the business, but you could have a large company that's a high-tech company essentially aggregating data for consumers and then making it available to providers. So, interoperability, mentioned Care Everywhere. We have EHX. We have that's the eHealth Exchange alert services. Use case everybody appreciates. We have business models that are basically expanding beyond simple commodity exchange. And as I mentioned, the Cures Act is accelerating the potential of third-party aggregators of patient data using APIs once the patient gives permission. TEPCA, I won't spend a lot of time on this, but this essentially provides a national backbone and potentially regional qualified health information networks to be connectivity brokers between HIEs. This is a part of the Cures Act and has been rolled out in the last 6 months. It seems to me quite successfully by the TEPCA team and also with the ONC support. So that is one way to exchange data. Next slide. So you're going to see a national flattening of the national infrastructure. Increasingly, you're going to have rules of the road that's going to allow better exchange between exchanges themselves, much like you're seeing within a single vendor network. And ultimately, you want to reduce hops between locations and flatten the infrastructure for all stakeholders. Frankly, users should not know what infrastructure they're using. It should be as agnostic to you as whether you're using Verizon or AT&T. So COVID and public health. Obviously, this is a key topic, and the exchange of lab and LOINC standards and SNOMED coding were a huge problem, but I think this has got everybody's attention now. Happy to discuss this if you have Q&As about it. Next slide, please. So quick discussion. So the Cures Act summary, we're really talking about consumer access to electronic health information, EHI. And so the plan here is that consumers will have access to a broad set of data at no extra charge on an unrestricted basis through open source APIs such as FHIR. So you can go to a third-party aggregator, give them permission to access your records at the various providers where you have a record, and they can aggregate that, and you can direct it yourself as a consumer between your caregivers. Provider directory, that's really important, really relative to care coordination and value-based care. We need to be able to attribute patients to providers and providers to patients, right? How can you coordinate care if you don't know what providers are seeing patients, and how do you know where to send your notes if you can't find providers attributed to a patient? Patient matching continues to be a challenge, but there's new algorithms out there, which is a whole other technical story, but we're trying to improve patient matching, and there's some new approaches to that. I think we'll just focus right here on 3 and 4, which is application programming interfaces and the US core data set. I should mention we are in USCDI version 2, and not 1, but initially Cures require the use of the core data set, and we'll look at a slide on that in just a second. So just very quickly, health information exchange and interoperability was based upon something called a consolidated clinical document, or a CCD. And it's very large program. If you're a provider and you've ever looked at a patient record and seen 50 or 60 or 70 pages that you really can't search very well, you're looking at a CCD. They're difficult to use, difficult to integrate, and all data are basically treated somewhat similar. So you don't recognize, for example, the key data elements such as, PAMI and other high utility data. So the CARES Act says we're going to support APIs, and FHIR is the leading standard for that, to replace CCDs. Next slide, please. So this is what a CCD looks like, just so you know. It has a total of 58 various templates. And you can see they're important: allergies, medications, discharge meds, dictation, and the like. The problem is every time you send a CCD, everything goes. And normally it would be received as a PDF, and not very easy to search, not very easy to look through, and really impossible to parse effectively into the receiving electronic health record. So while everything in here is important, you're really looking at, you might call a Concord solution, right? You're looking at something that can go faster than the speed of sound, when really what you need is a commuter jet. You don't really need all of this information. So this is what UCDI version 1 looks like. You can see that it's very simple, discrete, and it's been replaced by 2. And there are some new elements in 2 that include provenance, clinical notes, patient identifying information, and pediatric vital signs. Those are the new elements on the bottom that are now part of USCDI v2. So once again, all of these, as a provider, you can see how they're all really important to you, right? Now, here's what's really cool, is we can use FHIR, which is an API, to come in and just request labs, or we can do a query and just request clinical notes, or we can do a query and just request medications. But even right now, just if you do a bulk transfer of all the data elements, it's not as overwhelming as the CCD used to be. So this means 2 things. One is it's going to be easier to deal with on the receiving side and parse it into the record or make it available to the provider. And also, it's going to be easier to basically organize what you need and how it's used. So FHIR basically, APIs, application programming interfaces, is really a policy response to that bulk data of CCDAs and the HL7 standard, which many are frustrated with relative to all the bulk data, moving to more of a document-based exchange and a focus on high-value information. You also have third parties driving consumer-directed exchange. So you can see, if you're moving to modularity of data and moving to a means of exchange that can be far more discretely focused in terms of looking at the data elements, it's going to provide a lot of relief relative to the frustration that we face with interoperability. So questions for you. If you don't have questions for me, I have questions for you. Next slide, please. What will data integration look like? Will providers want a single record, unified? Or will they still want to know, this is what I've done, this is what we've done in our health system or at my practice, and I want to look at anything coming from another location as separate? What's the data provenance? Where's it from, and what about the liability of integrating data from outside sources? It's not really clear that the maximum level of integration is most important. Other questions I have for you is, will consumer-directed exchange by third parties be successful? Will consumers basically work with third parties to allow them to aggregate their health records, and then in effect be the exchange entity for that? Will vendors increase cooperation, or are you going to still continue to have a degree of competition between vendors? And then finally, what are we going to do about sources for data contribution that we need? What about behavioral health? I'm working on a project right now for the Commonwealth of Kentucky, with substance use disorder, and just the frustrations of data interoperability is so huge. And understanding who's being treated where, for example. What about community organizations? How do we get data from them and to them? And most importantly, how do we enhance care for the patients? So with that, I'll take questions. You can answer my questions, or you can ask me questions.
Wow, that was an incredible view of the past, the present, and a glimpse into the future. Thank you so very much for highlighting those policies that are being implemented to support a learning health system through the collection and secure exchange of electronic patient data. A few questions that we'd like you to address for our audience. In your presentation, you highlighted the numerous barriers to interoperability and data use across care settings. And you suggested that there will be solutions to those barriers in the very near term. What is the single most important solution, and what barrier will it address?
In my opinion, it's the marrying of the USCDI, the Universal Data Set, in its modular context, with the power of application programming interfaces to basically go in and capture discrete data elements. No longer will you have to deal with the frustration of trying to do the data mapping when you bring in an HL7 standards compliant a message and try to map it between even the same vendor systems or different vendor systems. Also, it will be able to concentrate on the data elements that's most important to particular providers at particular times. What's really opened my eyes is I was somehow always thinking that we just wanted max integration, right? That we just wanted to parse everything into one single record. But what we've learned in a lot of the qualitative research we've done over the past 2 years or so, 3 years, is really that a lot of the providers just want to know where to look for in the EHR the information and where it came from, right? Where do I find it? And what's its provenance? Who did the test? Can I trust it? Right? And that is a lot lower threshold to reach than actually parsing and having a single unified record. So I think there's going to be, and I think APIs and FHIR and USCDI sort of support that, small ball value. What's a money ball, right? You exchange the high value discrete pieces of information as opposed to everything. So that's what I think.
That's awesome. Clinicians are so extraordinarily busy that anything that makes their lives more simple and gives them the information exactly at the point of care is priceless. Another question: what does the vision you provided mean for individual providers and for patients, and how will care be affected?
Yeah, that's hope is. I know hope is not a strategy, right? But that's a really with the most important question, right? Hopefully, we are removing some of the burden from providers. We're able to get a more complete picture of the patient, so that with limited or a little effort, they're able to get the information they need at the point of care and to coordinate care, which perhaps is an overlooked area. And then I think for the patient, it's always frustrating because, if you look at the original data on patients signing up with patient portals, it was always such a struggle to get to 5%, right? And you still do not have the usage of patient portals that you would think. But there's a lot of problems with each portal is tethered to provider. I know my chart's trying to incorporate data and the like, but the idea is you free the data with third-party aggregators, and you have younger demographics who are used to using technology and data differently. That perhaps we're going to begin to look at data exchange and data use differently on the patient side too. Certainly the ability for the patient to be empowered, I believe, is being enabled. Whether the patient takes advantage of that enabling, right, is always the challenge.
Yes, most assuredly. But having it available and easy to use is the first step, at least. We want to thank you again so very much for the wealth of information that you shared with us, and you kind of gave us that glimpse into the future, as mentioned. We know that healthcare data is highly prized by not only the well-meaning healthcare industry and the clinicians and the policymakers, but it's also very highly prized by nefarious characters. And we want to have that balance between involving patients in the management of their healthcare. That's a really high priority, as you mentioned, but then we also need to protect that data as well. Our next presenter, Mr. James Hunter, is the Chief Information Security Officer here at Morehouse School of Medicine. And he'll discuss a little bit more about the 21st Century Cures Act, the requirements, how they will impact healthcare organizations, because they do pretty much impact all healthcare organizations. And we'll see how maybe we can achieve that balance between making the involving patients in aggregating and sharing their information while also keeping it secure. Mr. Hunter, please share with us.
Yes, thank you for having me. Glad to be with you today. Today we're going to look at two of the areas that we want to focus on, which is the how does the Cures Act final rule means for patient access, and then we'll also look at information blocking. So we want to look at those two, and when we look at the final rule and what it means for patients, they want to achieve to give the patient greater access to their records, and not just through paper, not just through notes. They want to achieve by doing that with smartphones and mobile devices that we have today and modern software apps. And also while doing this, they want to achieve this by making sure that patient privacy and security is the utmost importance. So they do use security technologies that have to be authorized within the applications and the APIs that was discussed earlier, to make sure that they are using protocols that the government and has given authorization to use. And one of those is such as OAuth 2, that is a very highly secure protocol, which is used in today's healthcare, travel, and banking applications. And so this also with patient access, this would also give the patient the ability to shop for care and manage costs. So they want to make sure that the patient is the payer of choice in healthcare by increasing the availability of data. So this is very important. And as we look into some of the details under HIPAA with patient access, some of this is covered where that the patient has the right to ask for the electronic copy of their data, of the PHI. And to have the provider electronically transmit the PHI to another person, as long as the patient has given explicit permission. Okay. And also under the CMS, we want to look at, they want to promote the interoperability program, and it's a requirement for the providers. It will enable the patient to actually view, download, and transmit electronic health records, EHI, and access their choice of the third-party health apps using those APIs as was discussed earlier. And also the API, once some of the requirements for the developers who create some of these APIs, we want to offer the certification for API functions so the app can retrieve whole or partial patient records, and also be able to apply security measures within those APIs. All right, so with the HIPAA and trust exchange framework, how will allow these health records to be transmitted? As you can see, as the image on the screen, there are various ways where patients can gain access to those digital health applications. And today we use a lot of those different devices, whether it's from a tablet or on your smart device, your smartphone or smart watch, or even your laptop. So these can be transmitted to these devices, and we want to make sure that the APIs that they use are interoperable and be used through different health applications to make it easier for them to be, for those applications to be created by healthcare entities at an easier, and also interoperable between health care applications. Also, we want to look at that by secure email, if requested by the individual and direct messaging through healthcare information networks, that they are encrypted and the email is secure. And also through patient portals. We all know that most of us will log into a patient portal, and we want to make sure that those are available to the patient access, to gain access to their patient records through portals. And within these portals, they should have, they should be able to engage the patient with online scheduling, secure messaging, prescription refills, etc., through the patient portal. Now we're going to look at some of the information blocking, on the final rule for information blocking, and it applies to 3 categories. And the first category we're going to look at is, you will see that you hear a lot about, is the category of an actor. So you say, what is an actor? The actor is the healthcare provider. It's the health information network or health information exchange. And it's the health IT developer or certified health IT who creates the applications and those APIs. So when we look at this, we say, what makes an individual or entity an information blocker? So what makes them an information blocker, and also why they are called a blocker, is because they are undertaking the practice of like to interfere or prevent or materially discourage access to exchange or use of electronic EHI. And that would make them an information blocker. So elements of the information that is information blocking is that an actor is regulated by the information blocking provision. It involves health information EHI. The practice of information blocking is likely to interfere with access or exchange or use of EHI. And the requisite knowledge by the actor, and also if it's not required by law, will make them an information blocker. And then it's not covered by an exception, because there are some exceptions with the information blocking rule. Next slide, please. Also, providers are also part of information blocking, which far as we look at, information blocking is where a practice knows is unreasonable and is likely to interfere with, prevent, or materially discourage access exchange or the use of electronic information. So a provider can also be an information blocking. And we ask ourselves, who are the providers and who are they? And if we look at the list, we can see that these can be a hospital, skilled nursing facility, and so forth, healthcare clinics, pharmacies, laboratories, physicians, practitioners, and so forth. And then we look at the next category with information blocking, who could cause information blocking, is the health IT developers, those who create the APIs, the applications, who develops IT for its organization, who engages or who develops or offers health information technology and engages in the practice that is subject of an information blocking claim, one or more health IT modules that is certified under a program for voluntary certification of health information technology. So health IT developers are also in this category. Let's look at some examples of information blocking. The health system requires staff to obtain patient written consent before sharing the patient's EHI with an unaffiliated provider. This is an example of information blocking. Also, a hospital customizes its EHR to include barriers to sending referrals and EHI to unaffiliated providers. So that's where that health IT and the APIs come into question there. An EHR vendor prevents, this can be through high fees or third-party clinical decision support application, from writing EHI into their EHR. Could be considered as information blocking. And also in healthcare and IT, a vendor discourages customers from getting data integration capabilities from a third party, claiming it would have the same functionality soon, while such functionality are in early stages of development. So we see that could also cause information blocking. There are some exceptions in information blocking. And one of those is the security exception. So a lot of times practices will have to implement certain security provisions to secure EHI. So as long as the measures are specifically tailored to the security risk and implemented in a consistent and non-discriminatory manner, then that would be an exception that would fall up under the security exception. Then there's also the infeasibility exception. And then this is denying requests for EHI if fulfilling the request is objectively and verifiably infeasible. The next is the health IT performance. This is a security exception where making technology temporarily unavailable for maintenance or updates, because we know that technology, whether it's for security reasons, whether it's for an upgrade of the application, they would have to actually be taken offline for a period of time for the maintenance and the updates to be implemented within the application or technology. So these will fall up under security exceptions. And then some more exceptions to be continued, also here to continue on, is the preventing harm exception. So these practices that are reasonable, these are practices that are reasonable and necessary to prevent harm to a patient or another person, provided that certain conditions are met that could cause harm to the patient. And then there are also a privacy exception. This is where practices implement to protect the privacy of EHI based in privacy laws tailored to specific privacy risk. You will see this more under HIPAA. And that was a quick through presentation that I really went through very quickly, about 12 slides. If there's any questions, we can answer, or we can actually forward them to the correct personnel. Thank you.
Well, thank you so very much, Mr. Hunter, for all you do to protect the availability, confidentiality, and availability, integrity of the data and systems here at Morehouse School of Medicine, as well as the insights you shared in your presentation on how the regulations will impact clinicians and their patients. As mentioned earlier, it was designed to give patients greater access to be able to manage their healthcare more effectively, and also to make information more shareable by the providers with each other, different places of service. So this information is readily available for all clinicians and healthcare organizations. On the Office of the National Coordinator's website, they have a very extensive ONC Cures Act Final Rule FAQ sheet that provides more insights into how these different scenarios that exist in healthcare organizations will be impacted by the 21st Century Cures Information Blocking Rule. Next, let's see if there are any questions in the Q&A. I neglected that one last time. All right, I have a question. The blocking rules address many of the reasons for the lack of information sharing. What additional measures do we need to take to assure that information is shared? Today, we still have these silos.